Imagine a grain of rice. It weighs almost nothing, right?
But just a tiny little speck.
Yeah, you could hold it on the tip of your finger, and a gust of wind would just blow it away. But, I mean, if a blood clot the exact size of that single grain of rice forms in the deep veins of your calf.
It can be catastrophic.
Exactly. It breaks loose,
Mm.
it travels up into the microscopic vasculature of your lung, and it can literally shut down your entire cardiopulmonary system in a matter of minutes.
It's terrifying when you think about it.
It really is. I mean, the human body is so incredibly resilient. It can build brand new blood vessels to bypass a blockage, right? Like shifting entire metabolic pathways just to keep you walking.
Oh, absolutely. The compensation mechanisms are amazing.
But at the same time, it's simultaneously so fragile that a tiny rogue piece of coagulated protein can just bring the whole machine to a grinding halt.
Well, that is the ultimate paradox of human physiology. Because when we study the body, especially in the context of internal medicine, we are not looking at a static piece of machinery.
Right. It's not like a car engine.
Exactly. We aren't looking at a broken bone where an X-ray gives us a clean, jagged white line and a simple binary answer, broken or not broken.
So what are we looking at then?
We are looking at a fluid, dynamic, highly pressurized ecosystem. I mean, every single system, the vessels, the heart, the lungs, the kidneys, they are all engaged in this constant, high-stakes negotiation for oxygen and flow.
And that negotiation is exactly what we are mastering today. Welcome to the Deep Dive. We're so glad you're here.
Yes, welcome.
Today, we are taking your MedSurg Exam 2 study guide, covering weeks 5 through 8, and we are turning it into an audio masterclass.
Which is going to be so helpful for you guys.
Absolutely, because our mission today isn't to just give you a list of symptoms to memorize.
Yeah.
I mean, memorization doesn't save a patient who is actively crashing.
No, it really doesn't. You need to know the why.
Right. We are going to build an understanding of the pathophysiology, the absolute why and how behind every disease process, so that the priority nursing interventions just become second nature to you.
Because if we connect this to the bigger picture, mastering the nursing process for these diseases means you will always know what to do first when your patient's condition changes.
And that's the ultimate goal, right? Clinical mastery.
Exactly. When you understand the mechanism, the intervention stops being just a bullet point to memorize. It starts being a logical necessity.
I love that.
Yeah, if you know exactly how the body is trying to compensate for a failing pump, you know exactly which medications and positional changes will help, and crucially, which ones will inadvertently kill the patient.
So when you walk onto the floor or, when you sit down for that massive MedSurg exam, you won't be guessing.
You'll know. You will know the exact physiological mechanism driving those symptoms.
Okay, so to build that intuition, we need a logical pathway. So here's our roadmap for this deep dive. We are going to follow the flow of blood.
Makes perfect sense.
Right. We'll start at the very edges of the body, down at the toes and the lower extremities, to see what happens when the pipes feeding the tissues or draining them get compromised.
The periphery.
Yep. Then we'll follow that compromised blood flow and the clots it can form up through the deep veins and straight into the lungs.
And then into the pump itself.
Exactly, the heart muscle.
Yeah.
We'll explore coronary blockages, system-wide heart failure, and then finally, we will trace the fluid out to the body's primary filtration system, the kidneys, to see how the plumbing manages all that pressure.
It really is a complete circulatory circuit. And at every single stop, we are going to extract the critical assessment findings, the priority actions, and the discharge teaching you need to keep these patients out of the hospital.
Let's do it. So, segment 1. We are starting our clinical journey by looking at the legs, specifically dealing with arterial versus venous vascular disorders.
And this distinction is everything.
Right, because mixing up an arterial problem with a venous problem will lead to an intervention that actively harms the patient.
You can literally cost someone their leg if you mix these up.
Wow. Okay, so we have to start with the supply side, which is atherosclerosis and peripheral artery disease, or PAD.
So PAD is fundamentally an issue of starvation.
Starvation of oxygen, right?
Exactly. The arteries are the high-pressure, thick-walled pipes responsible for delivering oxygen-rich blood from the heart down to the tissues. In PAD, the primary culprit is atherosclerosis.
Which people usually just think of as a clog, right? Like grease in a pipe.
Yeah, but it's not just a simple clog. It's actually a chronic inflammatory process. Lipid deposits, cholesterol, and fibrous connective tissue all build up inside the inner lining of the artery wall.
The intima.
Right, the
Okay.
intima. And over time, this plaque calcifies and hardens. It severely narrows the lumen, which is the hollow space where the blood actually flows.
So the tissues down on the legs just aren't getting the oxygen they need to survive.
Exactly. And that oxygen starvation leads to the absolute hallmark symptom of PAD, which is intermittent claudication.
Intermittent claudication.
Mm.
Okay, the clinical data describes this as an aching, cramping, or severe fatigue in the calves that is consistently reproduced by exercise and relieved by rest.
Yes.
But let's look at the mechanism. What is actually happening in the muscle tissue to cause that very specific type of burning pain?
Well, it's a classic mismatch between supply and demand. Imagine a patient with PAD is just sitting in a chair.
Okay, resting.
Right. At rest, the metabolic demand of their calf muscles is very low. So the narrowed atherosclerotic artery is capable of trickling just enough oxygenated blood past that blockage to keep the muscle cells functioning aerobically.
But then they stand up.
Exactly. The moment that patient stands up and starts walking to the mailbox, the calf muscles suddenly require a massive influx of oxygen and ATP to fuel those contractions.
And the artery just can't deliver it.
It can't. The occluded arteries simply cannot dilate to provide that extra flow. The supply is fixed.
So the muscle is forced to find energy another way.
Right. Because it lacks oxygen, the muscle immediately shifts from aerobic metabolism to anaerobic metabolism. And the byproduct of anaerobic metabolism is lactic acid.
Ah, lactic acid. Like when you work out too hard?
Exactly like that. As lactic acid rapidly accumulates in the muscle tissue, it irritates the local nerve endings, and that causes a severe burning, cramping pain. That is intermittent claudication.
And then when they stop walking,
The moment the patient stops walking and rests, the metabolic demand drops back down to meet that limited arterial supply. The lactic acid is slowly cleared away, and the pain fades. It is highly, highly predictable.
okay, but the clinical progression doesn't stop there, does it?
Unfortunately, no.
As the plaque grows and the lumen narrows even further, patients transition from intermittent claudication to something much more dangerous, which is rest pain.
Right. Rest pain is a huge red flag.
It's this persistent burning ache in the forefoot or the toes that happens when the patient is doing absolutely nothing. And the data shows a very specific behavioral compensation here.
What do they do?
These patients often have to sleep in a recliner where they literally dangle their affected leg over the side of the bed in the middle of the night just to get relief.
Yes, and as a nurse, when a patient tells you they are sleeping with their leg hanging off the bed, alarm bells should be ringing constantly.
Because it means it's getting worse.
It means it's severe. That is a massive indicator for critical limb ischemia. At this stage, the arterial blockage is so profound that the trickle of blood can no longer even meet the baseline, resting metabolic needs of the tissue.
So the cells are just constantly starving.
Exactly.
But wait, why is it specifically worse at night? Like, why the need to dangle the leg off the bed?
It all comes down to hemodynamics and gravity. When you are lying flat in bed, your heart has to pump blood horizontally down to your toes, right? You don't have the assistance of gravity pulling the blood down.
Oh, that makes sense.
And furthermore, when we sleep, our parasympathetic nervous system takes over. Our heart rate drops, and our overall cardiac output naturally decreases slightly.
Which is normally fine.
For a healthy person, it's perfectly fine. But for a PAD patient, that slight drop in pressure, combined with the loss of gravitational pull, means the blood simply cannot push past the arterial blockages in the legs.
So they dangle the leg to use gravity.
Precisely. By sitting up and dangling the leg over the edge of the bed, the patient is using the Earth's gravity to literally pull whatever blood it can down into those starving tissues.
That makes perfect physiological sense. Okay, so let's look at what we actually see when we assess these legs. If the tissue has been starving for months or years, the physical signs are going to reflect chronic malnourishment, right?
Absolutely. You'll see very specific changes.
The skin becomes cool to the touch. It looks incredibly shiny, dry, and completely hairless. And the toenails, they become thick, brittle, and opaque.
Yes, all classic signs.
And when you palpate the peripheral pulses, like the dorsalis pedis or the posterior tibial, they are either severely diminished or just entirely absent.
I always tell people to think of the body as an incredibly ruthless triage nurse.
Oh, I like that analogy. How so?
Well, the body has a limited, compromised supply of blood in that leg. It has to decide what lives and what dies. Hair follicles and nail beds are metabolically expensive, right? They require a robust, continuous blood supply to regenerate cells.
But muscle and bone are more important.
Exactly. Muscle tissue and bone are critical for survival. So the body triages the blood, it shunts the available oxygen to the deep muscles to keep the leg alive, and it completely cuts off the supply to the superficial skin, the hair, and the nails.
Wow.
That's why the hair falls out, the skin gets thin and shiny, and the nails turn into that thick, dead keratin.
That is wild. Now, the assessment data also highlights two very specific diagnostic color changes based on position: elevational pallor and dependent rubor.
These are key to look out for.
Let's break those down. Elevational pallor means that if I lift the patient's leg up in the air, the foot turns a ghostly pale white.
Right. And think about why. Because you are forcing a weak, low-pressure arterial system to fight an uphill battle against gravity to get past a blockage.
And it just can't do it.
It can't. The blood instantly drains out of the foot, leaving it pale and completely ischemic.
And then dependent rubor is the exact opposite. When the patient puts the leg back down, hanging dependently, the foot turns this dark, angry, purplish-red color.
Yes.
But wait, why does it turn purple instead of a healthy pink if blood is returning to it?
Because of profound vasodilation. While that foot was elevated and starving for oxygen, the microscopic capillary beds in the skin maximally dilated. They opened up as wide as possible, essentially screaming for blood.
Okay, so they're wide open.
Right. So when the leg is lowered, whatever poorly oxygenated, sluggish blood manages to make it past the blockage suddenly rushes into this massive network of wide-open capillaries.
Oh, I see.
The blood just pools there. It's stagnant and deoxygenated, which gives it that dark, ruddy, cyanotic tint rather than a bright, oxygen-rich pink.
Okay, so to quantify just how bad this starvation is, we use a diagnostic tool called the ankle brachial index, or ABI.
Yes, the ABI is crucial.
You are literally taking a systolic blood pressure reading at the ankle using a Doppler and dividing it by the systolic blood pressure reading in the arm.
It is a brilliantly simple metric. In a healthy person, the blood pressure at your ankle should be roughly equal to or slightly higher than the pressure in your arm.
So your ABI should be around 1.0.
Exactly. But if you have severe plaque blocking the arteries in your legs, the pressure is going to drop significantly by the time the blood reaches your ankle.
Right.
So if your arm pressure is 120, but your ankle pressure is only 60 because of all the blockages, your ABI is 0.5. The lower the number, the more severe the arterial disease.
Okay, so we understand the pathology and the assessment. Now we translate that into our priority nursing intervention. For a patient with PAD or any arterial insufficiency, the absolute priority regarding positioning is to keep the lower extremities positioned below the level of the heart.
Yes, neutral or dependent.
You keep them in a neutral flat position or slightly dependent. So if an artery is a kinked garden hose, we want gravity to help pull the water down.
That's a great way to picture it. Elevating the legs of a PAD patient will actively worsen their ischemia and cause excruciating pain.
Okay, but if dependent positioning is the absolute priority, what happens if this PA patient is also completely bedbound? Like, say they've had a stroke and can't dangle their legs. How do we manage the hemodynamics then?
In a bedbound patient, you use a reverse Trendelenburg position if the bed allows it.
So tilting the whole bed frame.
Exactly, tilting the entire bed frame so the head is higher than the feet, or at the very least, you keep the bed completely flat. You never ever put pillows under their knees or elevate their feet.
Okay, that makes sense. Now this brings me to a crucial point of clinical reasoning. We know that heat causes vasodilation. It relaxes the smooth muscle and blood vessels and opens them up.
Right.
So if I have a patient whose legs are freezing cold, turning pale, and crying out for blood because their arteries are narrowed, wait, if we want vasodilation, why can't I just put a heating pad on the patient's cold legs?
Yeah.
It seems like the perfect solution.
It does seem logical, but it is one of the most dangerous traps in nursing. It catches a lot of well-meaning professionals.
Really?
Yes. Applying direct heat to an ischemic extremity is strictly contraindicated. To understand why, we have to look at cellular biology. Heat doesn't just cause vasodilation. Heat acts as a catalyst.
What do you mean?
It drastically and rapidly increases the basal metabolic rate of any tissue it touches.
Oh, so the skin and muscle cells start working faster and consuming more energy.
Exactly. The moment you put a heating pad on that cold foot, the metabolic rate of those cells skyrockets. They suddenly demand a massive influx of oxygen and nutrients to sustain that heat-induced hypermetabolism.
But the artery is blocked.
Right. The underlying pathology is that the artery is physically occluded by hardened, calcified plaque. it cannot dilate. The supply is fixed.
Well,
So you have just artificially induced a massive demand that the body has absolutely no way of supplying. The cells burn through whatever meager oxygen they had in seconds, and they rapidly begin to die. You induce severe tissue necrosis.
you literally speed up the death of the limb.
Yes. And to make matters worse, patients with severe PA often have peripheral neuropathy.
From the chronic ischemia.
Right, the nerve damage. So they have severely decreased sensation. They will not feel the heating pad burning their skin until the damage reaches the deep tissues. You will cause a severe thermal burn that will never heal because there is no blood supply to repair the tissue.
That is a masterclass in understanding the why. Okay, so how do we keep them warm?
We promote systemic vasodilation. You put a warm blanket over their chest and abdomen. You give them a warm drink. You keep the room temperature comfortably warm.
So warm the core.
Exactly. By warming the core of the body, the brain signals the peripheral blood vessels to dilate naturally without artificially spiking the metabolic demand of the fragile tissues in the legs.
Brilliant. Let's shift to discharge teaching for PA. The primary non-pharmacological treatment we teach them is actually exercise.
Which surprises a lot of patients.
Right. We instruct them to walk to the point of pain, stop and rest until the pain subsides, and then immediately resume walking.
It seems completely counterintuitive to make them endure the claudication, but this ischemic stress triggers a process called angiogenesis.
Angiogenesis. Growing new vessels.
Yes. The body realizes the main highway is blocked, so over months of this exercise, it sprouts new, tiny capillary networks, collateral circulation, to bypass the blockage and feed the muscle.
They also need to avoid any constrictive clothing, never cross their legs, which physically compresses the arteries, and absolutely, unequivocally, they must stop using nicotine.
Nicotine is the most critical modifiable risk factor. It is a highly potent vasoconstrictor.
So it makes the narrow pipes even narrower.
Every single time they inhale cigarette smoke or use a vape, the nicotine forces those already narrowed atherosclerotic arteries to clamp down even tighter.
That's awful.
And furthermore, carbon monoxide from the smoke binds to hemoglobin, displacing oxygen, and the chemicals make the blood more viscous, increasing the risk of clots. For a patient with PA, smoking is quite literally a fast track to amputation.
Speaking of amputation, we need to look at the end-stage result of this tissue starvation, which is the arterial ulcer.
Yes, the arterial ulcer.
The clinical data describes PAD ulcers as deep, incredibly painful, circular wounds that look almost like someone took a hole punch to the tissue. They're usually found on the very tips of the toes, the web spaces between the toes, or the heels, basically the areas furthest away from the blood supply.
And because there is no blood flowing to the area, the wound bed isn't pink or bleeding.
What does it look like?
It is usually pale or covered in a hard, black, leathery tissue called dry gangrene.
Which brings us to a major priority intervention note. Never debride dry gangrene if there is no established blood supply.
Never.
Debridement, cutting away dead tissue, is standard wound care practice for almost every other type of wound to promote healing. Why is it strictly forbidden here?
Because healing requires a robust immune response, white blood cells, and building materials, right?
Right.
And all of those are delivered exclusively by blood. If you take a scalpel and cut away that stable, dry, black eschar on an arterial ulcer, you are creating an open, raw, exposed wound in an environment with zero blood flow.
It can't heal.
The body has absolutely no mechanism to heal that open wound. It will never close. And worse, it immediately becomes a prime target for systemic bacterial infection.
Oh, wow.
That dry gangrene is actually acting as a biological Band-Aid, sealing off the dead tissue. The priority is to keep it completely dry, keep it clean, and protect it from any further trauma until the limb can either auto-amputate, meaning the dead toe literally falls off on its own, or until a vascular surgeon can perform a bypass to restore blood flow before attempting to remove the dead tissue.
Okay, that covered the arterial side, the high-pressure supply lines. Now, let's flip the physiological script entirely and look at the low-pressure drainage system, venous insufficiency and stasis ulcers.
A completely different mechanism.
Right. If arterial disease is a failure to get oxygenated blood to the tissues, venous disease is a failure to get deoxygenated, waste-filled blood away from the tissues and back up to the heart.
The physics of the venous system in the legs are truly fascinating. Arteries have a thick muscular wall and the massive force of the heart pushing the blood down. Veins, on the other hand, are thin-walled, floppy, and low pressure.
And they have to fight gravity.
Exactly. They have to move blood from your foot all the way up to your chest, completely working against the force of gravity. To accomplish this, they rely on two mechanisms. First, the skeletal muscle pump.
How'd that work?
Every time you take a step, your calf muscles contract and physically squeeze the deep veins, shooting the blood upward.
Oh, like squeezing a tube of toothpaste.
Exactly like that. And second, they have microscopic, delicate bicuspid valves. Once the blood is squeezed up, these one-way valves snap shut so the blood can't fall back down between steps.
But in venous insufficiency, those delicate valves are destroyed or stretched out. Often this is due to deep vein thrombosis, obesity, pregnancy, or simply years of standing on hard floors.
Right. The valves become incompetent, they just don't close properly anymore. So the arterial system pumps the blood down to the foot perfectly fine, but when the veins try to squeeze it back up, the blood just falls right back down through the leaky valves.
It just pools there.
It pools in the lower legs, it creates a massive hemodynamic traffic jam, the hydrostatic pressure inside those lower veins skyrockets.
So this changes our assessment findings entirely. Instead of the sharp, cramping, oxygen-starved pain of claudication, the venous patient reports a constant aching, heavy, throbbing fullness in their legs.
Yes, very different kind of pain.
And instead of the leg being skinny, dry, and pale, the hallmark sign here is moderate to severe peripheral edema. The fluid from that high-pressure venous traffic jam is literally weeping out of the veins and flooding the surrounding interstitial tissue.
And if you try to palpate their pedal pulses, you might have a really hard time finding them.
Because the arterial flow is blocked.
No, not because of the arteries. Remember, the arteries are fine here, but because you're trying to feel a pulse through 2 inches of boggy, swollen edema. You often need to use a Doppler ultrasound just to hear the arterial flow beneath all that swampy fluid.
Now, I want to dive deep into a very specific, visually striking assessment finding associated with chronic venous insufficiency. It's called hemosiderin staining.
Yes, this is a classic sign.
What is the cellular mechanism behind this? Like, why do these patients' ankles literally turn dark brown?
This is one of the most elegant examples of pathophysiology manifesting visually. Because the venous pressure in the lower legs is chronically high, the microscopic capillaries are constantly stretched to their breaking point.
And they leak.
Eventually, they begin to leak. But it's not just clear plasma leaking out to cause edema. Actual red blood cells are forced out of the capillaries and trapped in the surrounding tissue.
And red blood cells are packed with hemoglobin, which is the protein that carries oxygen.
Precisely. And what sits at the center of every single hemoglobin molecule, an iron atom.
Okay, I see where this is going.
Once those red blood cells are trapped outside the vessel, they die and break down. The body's immune cells, macrophages, come in to clean up the cellular debris, but they leave the heavy iron molecules behind. Over time, that iron literally oxidizes.
It rusts.
It rusts inside the skin tissues. This permanent dark brown, rusty discoloration is called hemosiderin staining. You typically see it wrapping around the ankle and the lower calf, an area we clinically refer to as the gaiter area because it looks like they're wearing brown gaiters.
That is fascinating. The leg is literally rusting from the inside out. And because this tissue is constantly inflamed, flooded with fluid, and packed with cellular waste products that can't drain away, the skin eventually breaks down into venous stasis ulcers.
And we absolutely must contrast these with the arterial ulcers we just discussed.
Right. Arterial ulcers are dry, deep, and pale.
Venous ulcers are the exact opposite. Because the arterial supply is intact, the tissue has plenty of blood. So the wound base is usually a beefy, vibrant red, filled with healthy-looking granulation tissue trying to heal the wound.
But it can't heal.
It can't heal because it is essentially drowning. Venous ulcers are superficial, they have irregular, jagged borders, and they're highly exudative, meaning they weep massive amounts of fluid constantly.
Which perfectly dictates our priority interventions. If the problem is gravity pulling fluid down through broken valves, we have to reverse gravity.
Yes.
We elevate the patient's extremities above the level of the heart. We want gravity to help drain that accumulated fluid back into the systemic circulation so the kidneys can filter it out.
We also use mechanical force. We apply compression therapy.
Like what?
This could be an Uniboot, which is a semi-rigid zinc oxide dressing, or heavily graduated compression stockings. The goal is to physically squeeze the fluid out of the interstitial tissues and act as an artificial support structure for those floppy, failing veins, forcing the blood to flow back up.
But there is a massive limb-threatening caveat here. Before you wrap a patient's leg tightly in compression bandages, you absolutely must check their medical history and ensure their ankle brachial index is greater than 0.8 year.
This is a hard stop.
Why is this a hard stop?
Because patients don't always read the textbook, right? And they often have mixed vascular disease. A patient can have severe venous pooling and swelling while simultaneously having severe underlying arterial plaque blockages.
Oh, wow.
If you look at a swollen leg, assume it's just venous, and wrap it incredibly tight with a compression bandage, you are applying intense external pressure. If their arterial pressure is already critically low because of PA, your compression wrap will act like a tourniquet.
You'd cut off their blood supply?
You will completely crush their fragile arterial supply, you will successfully squeeze the edema out, but you will cause an ischemic necrosis of the entire foot. You always verify that the arterial system is strong enough to withstand the pressure before you compress a venous leg.
Incredible. Okay, let's put you, the listener, in the room right now to apply this knowledge. This is our first clinical scenario.
Let's do it.
Picture this. You're walking into room 402 to admit a new patient. The patient is a 65-year-old retired mechanic. He tells you, every time I walk to the end of my driveway to get the mail, my calves feel like they are locked in a vise. It burns so badly I have to sit on the curb for 5 minutes before I can walk back inside.
Classic.
You ask him to lie back in the bed, and as you pull up his pant legs, you notice his shins are completely hairless. The skin looks like polished wax. And as he lifts his legs to adjust himself, his toes turn a ghostly white.
Okay.
What is the underlying diagnosis here? And based purely on the hemodynamics, what is your first priority nursing action regarding how you position his bed?
The clinical reasoning here should be instantaneous. The burning pain that occurs reliably with exercise and stops with rest is the anaerobic lactic acid buildup of intermittent claudication. The hairless, waxy skin is the body's triage system, sacrificing superficial tissue due to chronic malnourishment. The ghostly white toes upon lifting are elevational pallor, the weak arterial pressure failing against gravity. Every piece of data points definitively to peripheral artery disease.
PAD, so what's the intervention?
Because this is an arterial starvation issue, your priority action regarding positioning is to harness gravity to help feed the tissue. You will instruct him to keep his legs in a neutral, flat position or slightly dependent below the level of his heart. You will make sure the foot of his bed is never elevated.
Spot on. We've mastered the chronic flow issues of the periphery. Now, segment 2. We need to transition to the acute, life-threatening pathways.
This is where things get really serious.
Because when you have venous stasis, when you have that traffic jam of blood pooling in the legs, you don't just get swelling and ulcers. Stagnant blood likes to clot. And when a clot forms in the deep veins, we are suddenly dealing with a rogue projectile. Let's trace the clot's journey, starting with deep vein thrombosis, or DVT.
A DVT is the origin point for one of the most lethal cascades in medicine. To understand how it forms, we have to look at Virchow's triad.
Virchow's triad.
Yes. These are the 3 fundamental pathophysiological risk factors that create the perfect storm for a blood clot. You usually need at least one, but hospitalized patients often have all 3 simultaneously.
Let's break down the triad. First is endothelial damage.
The endothelium is the smooth, Teflon-like inner lining of the blood vessel. As long as it is smooth, blood cells slide right past. But if that lining is torn or damaged, it exposes the underlying collagen.
And collagen triggers a reaction.
It does. The body views this exposed collagen as a leak that needs to be plugged. It immediately sends a swarm of platelets to the area, which stick to the collagen and begin forming a plug, activating the clotting cascade. Endothelial damage can happen from direct physical trauma, orthopedic surgery like a knee replacement, or even from the sheer internal force of an IV catheter scraping the vein wall.
Okay, the second factor in Virchow's triad is venous stasis. We touched on this with venous insufficiency.
Right. Blood is designed to move. When blood sits still, the heavy cellular components settle, and the naturally circulating clotting factors in the plasma are allowed to remain in close contact with each other for too long.
So they just start clotting on their own.
They begin to interact and trigger coagulation without any actual injury present. This is why prolonged bed rest, long flights, obesity, and heart failure, where the pump isn't moving the fluid effectively, are massive risk factors for DVT.
And the third factor is altered coagulation, or hypercoagulability. The blood itself becomes chemically prone to clotting.
This can be genetic, like having a factor V Leiden mutation, but it is often acquired. Sepsis creates a hypercoagulable state. Active cancer creates a highly thrombogenic environment. And crucially for our younger demographic, high estrogen states like pregnancy or the use of oral contraceptives significantly thicken the blood and increase clotting factor production.
So if you have a patient taking birth control pills who also smokes, which causes endothelial damage, and takes a 12-hour flight venous stasis, they have hit the Virchow triad jackpot.
Exactly. It's the perfect storm.
So the clot forms, usually deep in the popliteal vein of the calf or the femoral vein in the thigh. What does this actually look like when we are assessing the patient? The classic presentation is unilateral, massive swelling.
Unilateral is the key word. Only the leg with the blockage swells. The clot acts like a cork in the pipe. The arterial blood keeps pumping in, but the venous blood can't get out.
So the fluid just backs up.
The hydrostatic pressure builds up behind the clot, forcing fluid into the tissues of that specific leg. The leg will also feel noticeably warmer to the touch than the unaffected leg, and it will be tender.
But the tenderness isn't from the muscle, is it?
No, it is from the vein itself. The presence of the clot triggers a localized inflammatory response in the wall of the vein called phlebitis. That inflamed vein is what hurts.
Now, I want to highlight a massive trap here, one that catches a lot of veteran nurses and constantly shows up on board exams.
Hohmann sign.
Yes. The old-school traditional method of checking for a DVT was something called Hohmann sign. The nurse would quickly and sharply dorsiflex the patient's foot, pushing the toes up toward the shin to see if it caused deep calf pain. But the clinical data explicitly states, Hohmann sign is not a reliable indicator for DVT. Why have we abandoned this?
We abandon it because it is both useless and dangerous. Physiologically, pushing the foot back stretches the Achilles tendon and the calf muscles. A patient could have calf pain simply from a pulled muscle, a cramped tendon, or a Baker cyst, resulting in a false positive.
Right, there are so many reasons your calf might hurt when you stretch it.
Exactly. And conversely, a patient could have a massive DVT that isn't pressing on a nerve, resulting in a false negative. It is less than 30% accurate.
That's terrible.
But more importantly, think about the mechanics. You have a fragile, gelatinous blood clot clinging to the wall of a deep vein. By aggressively dorsiflexing the foot, you are violently compressing the calf muscles against the tibia, squishing that vein.
You'd literally dislodge it.
You could theoretically snap the clot loose, turning a localized leg problem into a lethal pulmonary embolism.
You literally launch the missile. Wow. So if we don't use Hohmann sign, how do we properly assess the swelling?
You use a simple objective tape measure. You measure the circumference of the affected calf and thigh at very specific intervals, mark the spots with a pen, and compare those exact measurements to the unaffected leg. It gives you hard, trackable data on whether the edema is expanding or resolving.
Okay, we also closely monitor their coagulation lab values, specifically PT, INR, and APTT, along with their platelet counts. What are these labs actually telling us?
They are essentially stopwatches for the clotting cascade. The body has two main pathways to form a clot. The extrinsic pathway, which is triggered by external tissue damage, and the intrinsic pathway, which is triggered by internal trauma inside the blood vessel.
Yeah.
The PT, or prothrombin time, and its standardized ratio, the INR, measure the speed of the extrinsic pathway. We monitor this specifically when the patient is taking warfarin, which is an oral anticoagulant.
And the APTT?
The APTT, or activated partial thromboplastin time, measures the speed of the intrinsic pathway. We monitor this constantly when a patient is on a continuous heparin the fourth drip. We are looking for these numbers to be elevated, meaning it takes longer for the blood to clot. We want them in a therapeutic range where the blood is thin enough to stop the DVT from growing, but thick enough that the patient doesn't spontaneously bleed out.
That brings us to the priority nursing interventions for a DVT. The overarching #1 goal is prevention of fragmentation. We must prevent that thrombus from breaking loose and traveling.
Which means strict bed rest initially. You do not want them walking around, utilizing that skeletal muscle pump to squeeze the vein and potentially dislodge the clot. You elevate the feet and lower legs above the level of the heart to help drain that massive pooling of fluid through alternative collateral veins.
And here is a vital point regarding thermal therapy. For a DVT, the standard intervention is to apply warm packs to the affected leg. We explicitly establish that warm packs are strictly forbidden in arterial disease because the arteries can't dilate to meet the heat-induced metabolic demand. Why is it safe and effective to use warm heat on a venous blood clot?
Because the arterial supply is perfectly healthy. In a DVT, the high-pressure oxygen delivery system is working fine. When you apply warm pack to a DVT, the heat penetrates the tissue and causes vasodilation.
So more blood flows in.
Right. The healthy arterial capillaries open up, bringing fresh, oxygenated blood to the inflamed area, which soothes the phlebitis, reduces the pain, and helps the body's immune system access the area to start breaking down the clot.
And obviously, we institute strict bleeding precautions once they are placed on anticoagulant therapy, whether that's a continuous IV heparin drip, subcutaneous enoxaparin, or oral warfarin.
And we must clarify a very common misconception here. Heparin and warfarin do not dissolve the blood clot.
Wait, really?
They are not clot busters. They are simply chemical roadblocks that prevent the existing clot from getting any larger and prevent new clots from forming. The body's own intrinsic lipolytic system, specifically an enzyme called plasmin, is what slowly dissolves and breaks down the DVT over several weeks.
Okay, but what happens if our interventions fail? What happens if the patient ignores the bed rest, or the clot is simply too unstable and it snaps off the vein wall? We are no longer dealing with a leg issue. We enter the nightmare scenario, the pulmonary embolism, or PE. Let's trace the anatomy of this catastrophe.
The clot breaks free from the popliteal vein and becomes an embolus, a traveling projectile. It shoots up the massive inferior vena cava, entering the right atrium of the heart. The right atrium pumps it into the right ventricle, and the powerful right ventricle slams it directly up into the pulmonary artery.
Straight into the lungs.
Right. The pulmonary artery immediately branches off into smaller and smaller arterioles within the lung tissue. The clot travels until the vessel becomes too narrow and it wedges itself tight.
It creates a massive roadblock in the pulmonary circulation.
Exactly. And this creates a phenomenon called dead space ventilation. The patient is inhaling, air is entering the alveoli, the tiny air sacs in that section of the lung. But the blood supply to those alveoli is completely blocked by the clot. The oxygen has no blood to bind to.
So they're breathing, but it's doing nothing.
Exactly. A massive section of the lung is suddenly rendered entirely useless for gas exchange.
Now, the clinical data makes a fascinating distinction in the assessment findings here. It states that for a pulmonary embolism, dyspnea is the most frequent symptom, while tachypnea is the most frequent sign. What is the clinical difference between a symptom and a sign?
A symptom is subjective. It is what the patient experiences and reports to you. Dyspnea is the sensation of shortness of breath. The patient will frantically tell you, I can't get any air in, I feel like I'm suffocating.
And a sign.
A sign is objective. It is what the nurse physically observes and measures. Tachypnea is a rapid respiratory rate, often over 30 breaths per minute. The patient feels like they are suffocating, the symptom, so their brainstem forcefully drives their breathing rate through the roof to try and compensate the sign.
Other critical signs include sudden pleuritic chest pain. Now, this isn't the heavy, crushing pain of a heart attack. Pleuritic pain is a sharp, stabbing pain that gets exponentially worse every time they try to take a deep breath, because the inflamed lung tissue is rubbing against the chest wall.
Yes, very sharp pain.
They'll also be tachycardic, sweating profusely, and they may present with hemoptysis, which is coughing up frothy, blood-tinged sputum as the lung tissue begins to infarct and bleed.
But the most striking assessment finding is often psychological. Severe, sudden anxiety and a profound feeling of impending doom.
Impending doom.
Yes. The patient's brain is suddenly starved of oxygen, and it triggers a massive sympathetic panic response. They will look at you with sheer terror because their body subconsciously knows it is dying.
Wow. So you walk into a room and your patient is exhibiting these signs. The priority nursing intervention, the first action, what do you do?
You recognize the catastrophic shift instantly. Do not leave the patient. You hit the call bell, call the rapid response team, notify the provider immediately, and your absolute first physical action is to administer oxygen.
Why oxygen first? If the blood flow is blocked, how does giving more oxygen through a mask help?
Because you have to maximize the efficiency of the lung tissue that is still receiving blood flow. If a clot blocks 30% of the lung, the remaining 70% has to do the work of the entire organ to keep the brain and heart alive.
Okay, that makes sense.
By slamming them with high-flow oxygen, you hypersaturate the healthy blood passing through the unblocked sections, aggressively fighting the systemic hypoxemia.
You also immediately place the patient in a semi-Fowler or high Fowler position. Sitting them up at a 45 to 90 degree angle uses gravity to drop the abdominal organs down, giving the diaphragm maximum room to expand, which instantly improves their ability to ventilate. Once they are stabilized, the provider will order a multi-detector computed tomography angiography, or MDCTA.
The MDCTA is the gold standard diagnostic test. They inject a bolus of radiopic contrast dye into an IV and run the patient through a high-resolution CT scanner. The dye lights up the pulmonary arterial tree in brilliant white, and the clot will show up as a stark, dark void.
So they can see exactly where it is.
Exactly. It tells the team exactly where the blockage is and how massive it is.
Okay, let's solidify this with our second clinical scenario. I'm putting you back on the floor. You are caring for a 55-year-old female patient who had major abdominal surgery 3 days ago. She's been reluctant to get out of bed due to the surgical pain. You were at the nurse's station when her call bell rings continuously. You run into the room. She is sitting bolt upright, clutching her chest. She looks terrified. She is sweating heavily, and you count her respiratory rate at some 4 breaths per minute.
Oh, boy.
Based on her history and presentation, what is your immediate priority nursing action?
Let's dissect the clues. First, her history. Major abdominal surgery and 3 days of strict bed rest. That is massive endothelial damage combined with profound venous stasis. She has 2 major risk factors from Virchow's triad. She likely developed a silent DVT in her pelvis or leg.
Okay.
The sudden, instantaneous onset of terror, sharp chest pain, and severe chypnea is the classic presentation of that clot breaking loose and becoming a pulmonary embolism.
So what's the first move?
Your first priority action is not to assess her surgical incision. It is not to give her pain medication. Your immediate priority is to administer high-flow oxygen to treat the hypoxemia, ensure the head of the bed is elevated to high Fowlers to maximize her ventilation, and yell for someone to call the rapid response team to initiate emergency cardiopulmonary stabilization. You are managing an airway and breathing crisis.
Masterful breakdown. We have successfully followed the blood from the stagnant veins of the legs into the microscopic blockade of the lungs. Now, segment 3. Let's follow the oxygenated blood out of the lungs and directly into the heart muscle itself. This brings us to the pump under pressure, coronary artery disease, angina, and myocardial infarction. We're looking at what happens when the vessels feeding the engine are compromised.
The heart is an absolute marvel of engineering. It is a relentless pump, beating 100,000 times a day, every day of your life. But the heart muscle itself, the myocardium, cannot extract oxygen from the blood inside its own chambers.
Wait, it's full of blood, but it can't use it.
Exactly. It requires its own dedicated plumbing system wrapped around the outside of the heart, the left and right coronary arteries. And there is a fascinating, almost counterintuitive mechanical quirk about how these arteries receive blood.
The clinical data highlights this explicitly. It states that the heart is uniquely perfused during diastole.
Most of the body gets its pulse of blood during systole, which is when the heart forcefully contracts and shoots blood out. But think about the physics of the heart muscle. When the thick left ventricle violently contracts during systole, it generates immense internal pressure.
So it squeezes its own blood vessels.
Yes. The coronary arteries buried inside that muscle are literally squeezed shut by the force of the contraction. Blood cannot physically flow through them. It is only when the contraction ends and the heart relaxes, the phase called diastole, that the pressure drops, the vessels spring open, and oxygen-rich blood rushes into the coronary arteries to feed the heart muscle.
So the heart feeds everyone else when it works and feeds itself only when it rests.
Exactly. And this quirk becomes a massive liability if the patient develops tachycardia, a rapid heart rate. If a patient's heart rate shoots up to 140 beats per minute, the time spent in the squeezing phase remains relatively constant. What gets sacrificed is the resting phase, diastole.
So it loses its feeding time.
The heart is beating so fast it barely has time to relax before it has to squeeze again. This puts the heart at an enormous risk for ischemia, especially if the patient has coronary artery disease.
Coronary artery disease, or CAD, is the exact same atherosclerotic process we discussed in the legs with PAD, just occurring in the coronary arteries. Plaque builds up, the pipes narrow, and supply cannot meet demand.
And just like in the legs, this mismatch manifests as pain. But instead of calf pain, it is chest pain, angina pectoris.
Right. And we need to clearly distinguish between the 2 main types of angina, stable and unstable. Stable angina is highly predictable. The patient's coronary artery is partially blocked by a stable plaque. The patient knows that if they walk up exactly 2 flights of stairs, the increased myocardial demand will outstrip the limited supply, and they will feel a heavy, squeezing pressure in their chest.
Yes, it happens with exertion.
Crucially, the pain is relieved when they sit down and rest, or when they take a single nitroglycerin tablet under the tongue. The supply-demand balance is restored.
Unstable angina, on the other hand, which is also called pre-infarction angina, is terrifyingly unpredictable. The plaque inside the artery has likely ruptured or torn. The body tries to heal the tear by forming a blood clot on top of the plaque, causing the artery to become critically narrowed, perhaps 95% occluded.
Wow.
This pain happens when the patient is completely at rest sitting on the couch watching TV. It lasts longer, it is far more severe, and most importantly, it is not relieved by rest or by taking nitroglycerin. It is a massive warning sign that the artery is about to close entirely.
Now, regarding critical assessments for angina, our clinical data contains a very important caveat. We have been trained by television to look for the classic presentation. A middle-aged man clutching the center of his chest, describing an elephant sitting on his chest with pain radiating down his left arm and up into his jaw.
Right, the Hollywood heart attack.
Exactly. But women, older adults, and patients with diabetes often present entirely atypically. They might not experience classic chest pain at all.
This is a critical point that saves lives. In women, the pathophysiology of CAD often affects the microvasculature, the tiny vessels, rather than the large main arteries, which changes the pain receptors triggered. In diabetics, chronic high blood sugar damages the nerves, autonomic neuropathy, so they literally cannot feel the chest pain.
So what do they feel?
These atypical patients might present to the emergency department complaining only of overwhelming, unexplained fatigue, severe indigestion that feels like heartburn, sudden nausea, or an unexplained shortness of breath. You must never dismiss a 70-year-old diabetic woman who comes in complaining of severe indigestion and sweating. You have to investigate her heart immediately with an ECG.
So we have a patient experiencing angina. What is the priority nursing intervention? What is your very first action?
The patient must immediately stop whatever they are doing and rest. You assist them into a bed or a chair, preferably in a semi-Fowler's position, to drop the diaphragm and make breathing easier.
We are instantly manipulating the demand side of the equation. Stop the physical exertion, decrease the workload of the heart, drop the oxygen demand down to baseline.
Exactly. Then you immediately acquire a 12-lead ECG to look for electrical changes in the heart, like ST segment depression or T-wave inversion, which indicate ischemia. And you administer sublingual nitroglycerin.
Let's dive deep into nitroglycerin. The protocol is up to 3 doses, taken 5 minutes apart. But how does it actually stop the chest pain?
Nitroglycerin works on multiple fronts. It converts into nitric oxide in the bloodstream, which is a powerful, smooth muscle relaxant. First, it dilates the coronary arteries themselves, attempting to physically open up the pipe and increase oxygen supply past the plaque. But more importantly, it causes massive systemic venodilation. It dilates the massive veins in the legs and abdomen.
How does dilating the veins in the legs help the heart?
By trapping the blood down there. Because the veins dilate, blood pools in the periphery. Less blood returns to the right side of the heart. This is called a reduction in preload.
Oh, preload.
Right. If less blood returns to the heart doesn't have to stretch as far or pump as hard to eject it. You drastically reduce the physical workload and therefore the oxygen demand of the heart muscle. The pain stops because the heart doesn't have to work as hard.
But if they take that first nitro, wait 5 minutes, take the second, wait 5 minutes and take the third, and the heavy crushing pain is still there. You are no longer dealing with simple ischemia. The plaque is completely ruptured. The clot has fully occluded the artery. You have crossed the threshold into a myocardial infarction, an MI, a heart attack.
The tissue is no longer just starving. It is actively dying. Necrosis has begun.
The critical assessments shift aggressively. The pain is sudden, severe, and relentless. The patient's sympathetic nervous system kicks into overdrive because of the dropping cardiac output. Their skin becomes cool, pale, and incredibly diaphoretic. They are drenched in sweat. And diagnostically, we shift from just looking at the ECG to monitoring cardiac biomarkers in the blood, primarily troponin.
Yeah.
What exactly is troponin, and why does it tell us the heart is dead?
Troponin is a complex of regulatory proteins that live strictly inside the structural fibers of cardiac muscle cells. They control the actual microscopic contraction of the heart. As long as the heart cell is alive, the troponin stays locked inside the cell membrane.
But when it dies?
But when the coronary artery is blocked and the heart cell dies from oxygen starvation, its cell membrane ruptures and bursts open. The troponin proteins spill out into the surrounding tissue and are washed into the bloodstream. When we draw blood and detect elevated levels of troponin, it is absolute, definitive proof that myocardial cells have physically burst open and died.
Because time is muscle, our priority interventions for an acute MI shift into high gear. The goal is to salvage as much of the myocardium as possible. The initial rapid medication protocol forms the classic acronym MONA. Those standard orders often initiate these simultaneously or in varying sequences based on presentation. MONA stands for oxygen, aspirin, nitroglycerin, and morphine.
oxygen to try and supersaturate whatever minimal collateral blood flow might be reaching the dying tissue. Aspirin is chewed immediately. It is an antiplatelet agent that stops the platelets from clumping together, preventing the clot inside the coronary artery from growing any larger. Nitroglycerin, as we discussed, to reduce preload and dilate the vessels.
And morphine. This is the one that trips up a lot of people. Obviously, an MI is agonizingly painful, and morphine is a powerful opioid. But why specifically morphine? Why not fentanyl or Dilaudid? What is the hemodynamic benefit of morphine?
Morphine is practically a miracle drug in an acute MI. Yes, it binds to opiate receptors in the brain to eliminate the excruciating chest pain, but its secondary effects are why we use it. First, it is a potent anxiolytic. It stops the sheer panic.
Which lowers their heart rate.
Yes, when a patient is terrified they are dying, their brain dumps massive amounts of adrenaline, causing severe tachycardia and vasoconstriction, which wildly increases the heart's oxygen demand and worsens the MI. Morphine blunts that sympathetic nervous system response, slowing the heart rate.
Okay, that's one benefit.
Furthermore, morphine acts as a mild vasodilator. Just like nitroglycerin, it relaxes the veins, pooling blood in the periphery, reducing the preload. It also relaxes the arteries, reducing the afterload, the resistance the heart has to pump against. By giving morphine, you eliminate the pain, slow the heart rate, and decrease the physical workload of pumping, completely shifting the supply-demand equation in the heart's favor.
Incredible. Let's test this intuition with our third clinical scenario.
Okay, let's hear it.
Picture this. You are working the night shift. You have a 68-year-old male patient who was admitted yesterday for monitoring of stable angina. At 2 a.m., his call bell rings. You walk in, and he is sitting up, clutching the center of his chest. He is sweating profusely. His skin is pale, and he tells you, "I woke up from a dead sleep with this crushing pain. It feels like a cinder block is on my chest. I took one of my nitroglycerin tablets from the bedside table 5 minutes ago, but the pain hasn't changed at all. It's an 8 out of 10.
Okay, classic presentation.
Walk me through the clinical reasoning here. What is your priority nursing action?
Let's look at the behavior of the pain. He has a history of stable angina, which we know is predictable and occurs with exertion. But this pain woke him up from a dead sleep. It occurred entirely at rest. Furthermore, it did not respond to the first dose of nitroglycerin.
So stable angina is out.
This completely rules out stable angina. The sudden onset, the intense diaphoresis, and the failure of the vasodilator point directly to unstable angina or an actively evolving acute MI. The artery is critically occluded.
What's the priority action?
Your priority actions must be rapid. First, administer a second sublingual nitroglycerin dose immediately, since exactly 5 minutes have passed since his first dose. Simultaneously, apply oxygen via nasal cannula to maximize tissue oxygenation. Press the call button and order an immediate 12-lead ECG to be brought to the room to check for ST elevation.
And if the pain doesn't go away?
You will wait 5 more minutes. If the pain is still present, you give the third and final dose of nitroglycerin. If it remains unrelieved after that third dose, you are initiating emergency protocols for an acute MI, calling the rapid response team, contacting the cardiologist, and preparing the patient for an immediate transfer to the cardiac catheterization lab. Every minute you delay, thousands of heart cells die. Time is muscle.
That perfectly transitions us to the post-intervention priorities. The patient is rushing to the cath lab for a PCI, a percutaneous coronary intervention.
This is mechanical reperfusion. The cardiologist threads a long, thin catheter into an artery in the wrist or groin, snakes it all the way up into the heart, and forces a tiny balloon into the blocked coronary artery. They inflate the balloon at incredibly high pressure to literally smash the atherosclerotic plaque against the artery wall, opening the pipe. They then leave a tiny wire mesh tube, a stent, expanded inside the artery to act as scaffolding and keep it permanently propped open.
And there's a huge time constraint here, right?
The golden, non-negotiable metric here is that the door-to-balloon time must be less than 60 minutes. From the moment the patient hits the ER doors to the moment that balloon inflates in their heart, you have 1 hour to prevent irreversible, massive heart failure.
So, assuming a successful PCI, the patient returns to your unit. The blockage is fixed. The heart is reperfusing. What is your critical assessment priority now?
Your focus shifts entirely to the access site where they inserted the catheter. They usually use the femoral artery in the groin or the radial artery in the wrist. During the PCI, the patient is pumped full of massive doses of 5-E heparin and antiplatelets to prevent clots from forming on the new metal stent. Their blood is incredibly thin. That tiny puncture hole in their major artery is a massive, life-threatening bleed risk.
So you're watching for bleeding.
You are constantly assessing the site for external bleeding, swelling, or the formation of a hard, painful lump under the skin, which is a hematoma.
If the surgeon used the femoral approach in the groin, the priority nursing intervention is incredibly strict. You must keep the patient flat in bed, and that affected leg must remain completely straight and immobile for up to 6 hours. Why is bending the knee so dangerous?
The femoral artery is a massive high-pressure pipe sitting right in the crease of the hip. When they pull the catheter out, they hold intense pressure until a fragile internal clot forms to plug the hole. If the patient bends their hip or knee, the physical flexing of the muscle and tissue will pop that fragile internal clot right off the artery.
And they'll bleed out.
Because the artery is deep inside the pelvis, you won't necessarily see blood pooling on the bed sheets. The patient will bleed internally into the retroperitoneal space. They can lose liters of blood into their abdominal cavity in minutes. Their blood pressure will crash and they will go into hypovolemic shock. You must keep that leg completely straight.
Another critical intervention post-PCI is administering continuous IV hydration. This isn't just to keep them hydrated, it is specifically to flush out the radiopaque contrast dye used during the procedure.
The dye used to visualize the coronary arteries is highly nephrotoxic. When it is filtered by the kidneys, it generates reactive oxygen species that physically damage and kill the delicate cells of the renal tubules. We have to run a steady stream of IV normal saline to keep the kidneys flushing at high volume, diluting the dye so it doesn't have time to sit in the tubules and cause an acute kidney injury. You will be rigorously monitoring their BUN and creatinine levels.
Let's clarify that. What exactly are BUN and creatinine, and why do they tell us the kidney is failing?
Think of your muscles and your protein metabolism as an engine. Like any engine, they produce exhaust fumes waste products. Creatinine is the constant daily exhaust fume produced by muscle breakdown. Blood urea nitrogen, or BUN, is the exhaust fume produced by protein digestion in the liver. A healthy kidney acts like an open chimney, constantly filtering these toxins out of the blood and venting them out of the body in the urine. If the contrast dye kills the kidney cells, the chimney gets blocked. The kidneys can no longer filter the blood. So, the exhaust fumes, the BUN and creatinine, build up rapidly in the bloodstream. If you draw a lab and see the creatinine level spiking, it means the kidneys are actively failing to clear waste.
This is a perfect example of the ecosystem we talked about. You fix the heart, but the chemical you use to fix the heart attacks the kidneys, so you have to flood the system with fluid to save the kidneys, but that fluid adds volume workload back to the newly fixed heart. It's a delicate balancing act.
It's all connected.
Now, what if the atherosclerotic blockages are too severe, too calcified, or there are too many of them to fix with a balloon? The patient bypasses the cath lab and goes to the OR for a CABG, a coronary artery bypass graft, open heart surgery.
The surgeon takes a healthy vein from the patient's leg or an artery from their chest wall and literally sews it into the heart, creating a brand new detour around the blockages.
The post-op monitoring for a CABG patient is incredibly intense because they have just been subjected to the trauma of a cardiopulmonary bypass machine. The clinical data flags two massive, life-threatening complications to monitor for. First, cardiac tamponade.
The heart sits inside a tough, fibrous, double-layered sac called the pericardium. Normally, there's just a tiny drop of lubricating fluid between the layers so the heart can beat smoothly. But after a CABG, the heart is traumatized and bleeding. Surgeons leave chest tubes inside the pericardial space to drain that post-op blood out into a plastic canister on the floor.
Right, to keep the space empty.
Cardiac tamponade occurs when those chest tubes suddenly become blocked by a clot. The blood continues to leak from the surgical sites, but it can no longer drain out. It rapidly fills the pericardial sac. Because the outer sac is tough and inflexible, the accumulating blood squeezes inward, physically crushing the heart. The heart literally cannot expand to fill with blood.
What are the critical signs that this is happening?
The primary immediate giveaway is a sudden, abrupt stop in the drainage from the chest tubes. 1 hour, you have 100 milliliters of dark blood draining, and the next hour, nothing. Suddenly, the patient's blood pressure bottoms out severe hypotension because the heart can't fill, so it can't pump. And if you listen to their chest with a stethoscope, the heart sounds will be incredibly distant and muffled because you are trying to hear the valves closing through 2 inches of trapped, thick blood. This is a surgical emergency. The chest must be cracked back open to release the pressure.
The second major monitoring point after a CABG is maintaining strict urine output. The parameter is that it must remain greater than 0.5 millimeters per kilogram of body weight per hour.
Why is urine output such a critical metric for a patient who just had heart surgery?
Because urine output is the ultimate real-time window into cardiac output. The kidneys are incredibly greedy organs. They receive 20% of the blood pumped by the heart every minute.
Wow, 20%.
Yes. If the newly bypassed heart is weak and failing, or if the patient is bleeding internally and losing volume, the blood pressure drops. The kidneys instantly sense this drop in flow. To protect themselves and conserve fluid for the brain, they clamp down and completely stop making urine. If a CABG patient's urine output suddenly drops below that 0.5 millibella threshold, you know instantly that the heart pump is failing to perfuse the systemic organs.
You also have to teach the patient a very specific physical intervention regarding their incision. They must use a cough pillow. Whenever they need to cough or do their deep breathing exercises, they have to hold a firm pillow tightly against their chest.
To perform the CABG, the surgeon had to saw their sternum, their breastbone completely in half, and crank their rib cage open. It is wired back together, but it takes months to heal. When a patient coughs, it generates explosive intrathoracic pressure. Without the physical splinting of the pillow pressing inward, a violent cough could literally snap the wires and separate the sternum, which is a catastrophic complication called sternal dehiscence.
Which perfectly transitions us to segment 4, exploring what happens when the pump fails permanently. We've talked about fixing the acute plumbing blockages with stents and bypass grafts. But if a patient suffered a massive MI before they got to the hospital and a large portion of their left ventricle died and turned to scar tissue, we are no longer dealing with a plumbing problem. We are dealing with a permanent mechanical failure. We are looking at heart failure.
Heart failure, or HF, is a clinical syndrome characterized by a simple premise. The heart cannot pump enough blood to meet the metabolic demands of the body.
And there are two main types, right?
It can be a systolic failure, meaning the left ventricle muscle is so weak, thin, and floppy from a past heart attack that it cannot squeeze hard enough to eject the blood forward. Or it can be a diastolic failure, meaning the ventricle muscle is thick, stiff, and hypertrophied from years of high blood pressure, so it cannot relax and stretch enough to fill with blood in the first place. Whether it can't squeeze or it can't fill, the end result is the same. Cardiac output plummets.
And here is where the clinical data reveals a cruel, tragic irony about the human body. The body tries to fix the low cardiac output, and in doing so, it actually destroys a heart faster.
It is the most devastating physiological trap in medicine. We call it compensatory mechanisms. When the failing heart drops the cardiac output, the blood pressure falls. The baroreceptors in the aortic arch and the kidneys instantly sense this drop.
And the brain freaks out.
The brain is not smart enough to know that the heart muscle is permanently damaged. The brain just registers low pressure and assumes we must be bleeding to death in the woods or we are severely dehydrated, we need pressure now.
So it pulls the fire alarms.
Exactly. It immediately activates the sympathetic nervous system, dumping adrenaline into the blood. This causes massive systemic vasoconstriction, clamping down all the arteries to raise the pressure, and forces the weak heart to beat faster. Simultaneously, the kidneys activate the RAAS pathway, the renin-angiotensin-aldosterone system.
We need to deep dive into RAAS because it is the target of almost every heart failure medication. How does it work?
When the kidney senses low flow, it releases an enzyme called renin. Think of renin as the first domino.
Okay, renin.
Renin circulates and converts a liver protein into angiotensin I. As angiotensin centerline passes through the lungs, an enzyme called ACE converts it into angiotensin II.
And angiotensin II is the bad guy here.
Angiotensin II is one of the most potent, vicious vasoconstrictors in the human body. It crushes the blood vessels down to a pinpoint. Furthermore, angiotensin II tells the adrenal glands to release aldosterone.
What does aldosterone do?
Aldosterone goes straight to the kidneys and commands them to hoard every single molecule of sodium they can find. And because water always follows sodium, the body retains massive amounts of water, artificially expanding the blood volume.
But the patient isn't bleeding. They aren't dehydrated. The pump is just broken.
That is the tragedy. So now picture this weak, floppy, failing left ventricle. It is already struggling to pump a normal amount of blood. Suddenly, because of the sympathetic nervous system and angiotensin II, the vessels it has to pump into are clamped down to the size of a straw, a massive increase in afterload.
Oh, no.
And because of aldosterone, the body is flooded with an extra 5 liters of retained water that the weak heart now has to pump a massive increase in preload. The compensatory mechanisms force a dying engine to push twice the weight up a steeper hill. It dramatically accelerates the failure of the heart muscle.
So the body is literally killing itself.
Yes. This is exactly why the cornerstone medications for heart failure are ACE inhibitors, which stop the formation of angiotensin II, and beta blockers, which block the adrenaline. We are chemically blocking the body's natural urge to compensate.
That is profound. And because the pump is failing against all this extra fluid, the fluid has to go somewhere. It backs up. This dictates our critical assessment findings, which we divide anatomically into left-sided and right-sided heart failure. It is all about where the traffic jam backs up to.
Left-sided heart failure fails backward into the lungs. The left ventricle is supposed to pump blood out to the body. When it fails, the blood backs up into the left atrium and then pushes backward into the pulmonary veins, which drain the lungs. The hydrostatic pressure inside the delicate lung capillaries skyrockets, and fluid is forced out into the microscopic alveoli air sacs.
So the symptoms are entirely respiratory. The patient is literally drowning in their own serum. They present with severe dyspnea, orthopnea, which is a terrifying inability to breathe when lying flat because the fluid spreads out across the lungs, a dry, hacking cough, and when you listen with the stethoscope, you hear coarse crackles bubbling in the lung bases. Their oxygen saturation will plummet.
Right-sided heart failure fails backward to the rest of the body. The right ventricle is supposed to pump blood into the lungs. If it fails, often because the left side failed first and created high pressure in the lungs, the blood backs up into the right atrium and then backward into the superior and inferior vena cava.
So the systemic veins get backed up?
The systemic venous system becomes engorged. When you look at the patient's neck, you will see jugular venous distension, or JVD. The jugular vein is bulging like a rope because of the backup of pressure. The fluid is forced out into the tissues, causing massive pitting-dependent edema in the legs and sacrum.
And the organs.
It backs up into the liver, causing hepatomegaly, a painfully enlarged liver. It leaks into the abdominal cavity, causing ascetans, making their stomachs swell like they are 9 months pregnant. And because they are retaining gallons of water, they experience rapid, massive weight gain.
Which brings us to the priority interventions in discharge teaching for heart failure, which revolve entirely around managing that fluid overload and protecting the fragile pump. You must rigorously track strict intake and output, INOs, in the hospital. But more importantly, you must perform strict daily weights.
Daily weights are the single most sensitive, objective indicator of fluid status, far more accurate than trying to measure urine in a cup. 1 liter of retained water weighs exactly 1 kilogram or 2.2 pounds.
So if they gain 3 pounds overnight?
If a heart failure patient gains 3 pounds overnight, they did not eat 3 pounds of fat. They retained nearly 1.5 liters of fluid, and they are heading into an acute exacerbation. They must weigh themselves every single morning at home at the same time, in the same clothes, after voiding.
You promote activity tolerance by alternating periods of rest and activity. You want them moving to prevent clots, but you cannot exhaust the failing pump. And from a dietary perspective, they must adhere to a strict, low-sodium diet, usually less than 2 grams a day.
Because sodium is the enemy. Where sodium goes, water follows. If they eat a salty bowl of canned soup, their blood sodium spikes, triggering the release of antidiuretic hormone. They will drink more, their kidneys will retain the water to dilute the salt, their blood volume will expand, and the failing heart will drown under the extra workload.
Intimately tied to this workload is hypertension, or high blood pressure. Chronic hypertension is the primary driver that causes the heart muscle to thicken and eventually fail, because it forces the heart to constantly pump against high-pressure resistance.
The clinical guidelines from the ACC and AHA have shifted over the years, and the exam wants you to know the current parameters. Normal blood pressure is defined as a systolic less than 120 and a diastolic less than 80. An official diagnosis of hypertension is made when the average blood pressure on 2 or more careful readings on 2 or more different occasions is 130/80 or higher.
I want to spend a moment here differentiating between 2 acute hypertensive crises that show up constantly in practice: hypertensive emergency versus hypertensive urgency. Both involve a severely elevated blood pressure, usually an absolute systolic over 180 or a diastolic over 120. Numbers are identical. So how do we clinically distinguish between an emergency and an urgency?
It has nothing to do with how high the number is and everything to do with the consequence of that pressure. The dividing line is target organ damage.
Target organ damage.
A hypertensive emergency means the blood pressure is sky high, and there is clinical evidence that the extreme pressure is actively destroying organs right now in real time. The pressure is tearing the aorta, or blowing out vessels in the brain, causing a stroke, or crushing the delicate glomeruli in the kidneys, causing acute renal failure, or causing an acute MI.
It's happening right then.
Because tissue is actively dying, it is an emergency. It requires immediate admission to the ICU and aggressive minute-by-minute titration of intravenous vasodilators to bring the pressure down quickly but controlled.
And an urgency.
A hypertensive urgency means the pressure is sky high, but there is no evidence of impending or active organ damage yet. The patient might be asymptomatic, or they might just have a severe headache, anxiety, or a nosebleed. The pipes are under intense stress, but they haven't burst. It is serious, but because the organs are still perfusing, we don't want to crash their pressure with IV meds, which could cause a stroke. We treat urgency by gradually lowering the blood pressure over hours or days using oral medications, often increasing their home dosages and arranging close outpatient follow-up.
Emergency means damage is actively happening. Urgency means the damage hasn't happened yet. That is a brilliant distinction.
Okay.
Okay, we have navigated the arteries, the veins, the lungs, and the heart pump itself. We have discussed how fluid volume overloads the system. Now, segment 5. Let's follow that fluid out to the body's primary filtration and plumbing system. We are transitioning to genitourinary disorders, and we'll wrap up with an infectious outlier from our peripheral assessment.
The plumbing system of the body is all about flow. When flow is obstructed or introduced to foreign bacteria, the system breaks down.
Starting with the most common disruption, urinary tract infections or UTIs.
UTIs are almost always ascending infections. The urinary tract, the bladder, the ureters, the kidneys is a sterile environment. But the urethra, the exit pipe, is exposed to the outside world. Bacteria from the GI tract, most commonly E. coli, migrate to the urethra, climb up the pipe, and colonize the bladder wall. This causes severe inflammation of the bladder lining called cystitis.
The critical assessments reflect that inflamed, irritated bladder. The patient will experience dysuria burning pain with urination. Because the bladder wall is swollen and hypersensitive, it can't hold much fluid without triggering stretch receptors, leading to extreme frequency and urgency. They constantly feel like they have to go, but only pass tiny amounts. And the urine itself changes. It becomes cloudy due to the presence of white blood cells and bacteria, and it develops a strong foul malodor.
The clinical data also flags a major preventable risk factor for hospitalized adults: the use of indwelling urinary catheters, which lead to CODIs or catheter-associated UTIs.
Why are catheters so risky?
The urinary catheter is a plastic tube sitting directly inside the sterile bladder, protruding out into the non-sterile world. It defeats the body's natural flushing mechanism. Bacteria love plastic. They form impenetrable biofilms on the surface of the catheter and use it as a superhighway to march straight into the bladder. Every single day a catheter is left in place, the risk of a systemic infection skyrockets. The most important nursing intervention for a COTI is to advocate for the removal of the catheter the absolute minute it is no longer medically essential.
For a standard UTI, the priority interventions in discharge teaching focus on eradicating the bacteria and flushing the system. We administer prescribed oral antimicrobials and often urinary analgesics or antispasmodics to stop the bladder from constantly contracting. You can apply a warm heating pad to the perineum to relieve the intense cramping pain. But the most important teaching point is hyperflushing. We encourage liberal fluid intake, 3 to 4 liters a day of water. We want them constantly producing urine to physically wash the bacteria off the bladder wall and out the urethra.
The data also specifically mentions cranberry juice. This isn't just an old wives' tale. There is a cellular mechanism here. E. coli bacteria have tiny hair-like appendages called fimbriae that they use to physically latch onto the cells lining the bladder wall, preventing them from being washed away.
And cranberry juice stops that.
Cranberry juice contains compounds called proanthocyanidins. These compounds bind to the E. coli fimbriae, essentially capping them, making the bacteria slippery so they cannot adhere to the bladder wall. They just slide right out with the urine stream.
That is amazing.
Right.
They also need to be taught to void every 2 to 3 hours to prevent stagnant urine from pooling and to strictly avoid urinary tract irritants like coffee, tea, citrus juices, and alcohol, which exacerbate the cystitis pain. Now let's look at what happens when the plumbing gets blocked by a physical rock: renal calculi or urolithiasis, kidney stones.
The kidneys filter excess minerals out of the blood, most commonly calcium oxalate or uric acid. Normally, these minerals stay dissolved in the liquid urine, but if the urine becomes too concentrated because the patient is dehydrated or the pH shifts, these minerals crystallize. They bind together and form a hard, jagged stone inside the kidney. The stone itself, sitting in the kidney, is often painless. The agony begins when the stone drops into the ureter, the tiny millimeter-wide muscular tube connecting the kidney to the bladder.
And the pain from a kidney stone passing through a ureter called ureteral colic is legendary. It is often described by patients as worse than unmedicated childbirth. It is a severe, radiating, ripping agony that starts in the flank and shoots down into the groin.
Because the ureter is violently spasming, trying to push a jagged rock through a tube that is too small for it, the sheer intensity of the pain triggers the vagus nerve, causing profound nausea and vomiting.
The critical assessments reflect this radiating pain and diaphoresis. But a much more dangerous sign is oliguria or anuria, a sudden, severe drop or complete stop in urine output. If a large stone gets wedged and completely occludes the ureter, the urine backs up into the kidney. The pressure builds, stretching the kidney capsule hydronephrosis, which can destroy the delicate nephrons and cause permanent renal failure.
The priority nursing intervention for the stone itself is strict monitoring. You must strain all of the patient's urine through a fine mesh filter. You have to catch any stones or gravel they pass so it can be sent to the lab. If we know the chemical composition of the stone, we can alter their diet to prevent the next one.
You also must treat the severe pain immediately with opioid analgesics or potent IV NSAIDs to reduce the ureteral inflammation. But here I want to look at the reasoning behind positioning. Usually when a patient is in absolute 10 out of 10 agony, pale and sweating, we tell them to lie still and rest in bed. But the clinical guidance here dictates that while you assist them to a position of comfort, you should actively encourage ambulation if it brings any relief. Why on earth are we making a patient in agonizing pain walk down the hallway?
Because lying in bed does absolutely nothing to fix the mechanical obstruction. The pain is caused by the stone being stuck. The ureter uses a squeezing motion called peristalsis to move fluid down. When the patient walks, two things happen. First, gravity pulls downward on the stone. Second, the physical jostling and movement of the body gently vibrates the internal organs.
So it shakes the stone loose.
This combination of gravity, vibration, and peristalsis helps physically nudge and push the jagged stone further down the ureter toward the wider bladder. It hurts intensely while it's moving, but passing the stone out of the narrow tube is the only way to actually relieve the underlying cause of the pain. Walking is quite literally a mechanical intervention.
Fascinating. Briefly touching on the surgical side of the plumbing. Urinary cancers and elimination. If a patient develops advanced bladder cancer, the surgeon may have to perform a radical cystectomy, completely removing the bladder. They then create a urinary diversion, like an ileal conduit. They take a piece of the patient's small intestine, sew the ureters into one end, and bring the other end out through the abdominal wall to create a stoma, where the urine continuously drains into a bag.
The post-op nursing priority here is perfusion assessment. You must inspect that stoma constantly. Because it is made of intestine, it requires a robust blood supply. A healthy stoma should be a vibrant, beefy red or bright pink, and it should be moist. If you look at the stoma and it is pale, dark purple, or black, it means the blood supply to that piece of bowel has clotted off or been strangulated. The tissue is ischemic and dying. It is a massive surgical emergency, and the provider must be called immediately.
And for non-surgical dysfunctional voiding issues in the general population, like stress incontinence, leaking when you sneeze or laugh, or urge incontinence, the sudden uncontrollable need to void, the interventions are behavioral. You teach timed voiding, having them go by the clock to retrain the bladder capacity. You use biofeedback to help them isolate and strengthen the pelvic floor muscles. And you can administer anticholinergic medications, which block the parasympathetic nervous system from causing the bladder muscle to constantly spasm.
All right, to wrap up our clinical material, we have to circle all the way back to the periphery, back to the skin of the legs for one highly infectious outlier, cellulitis.
Cellulitis. We spent a lot of time talking about ulcers and edema breaking down the skin barrier in the lower legs. When that barrier breaks, the bacteria that naturally live on our skin, primarily Staphylococcus and Streptococcus, invade the deep dermis and the underlying subcutaneous tissues. They multiply rapidly, releasing toxins that trigger a massive localized inflammatory response.
The assessment findings are classic signs of deep infection. The affected leg will be bright red, intensely swollen, tight, glossy, and exquisitely hot to the touch. The patient will likely have a systemic fever and chills as the bacteria enter the lymphatic system.
The pharmacological management is straightforward. Oral antibiotics for mild, localized cases and broad-spectrum IV antibiotics for severe cases, or patients with systemic signs of infection. But the specific nursing interventions regarding temperature application are what you will be tested on because they require critical thinking. First, You elevate the affected extremity 3 to 6 inches above heart level. Just like with venous insufficiency, you are using gravity to help drain the massive amount of inflammatory edema fluid out of the tissue.
Second, the protocol for temperature application happens in phases. Initially, you apply cool packs to the infected area every 2 to 4 hours until the severe inflammation resolves. Then, once the angry swelling goes down, you transition to applying warm packs.
We need to unpack the physiology of this because it directly contrasts with our DVT intervention. Remember, for a DVT, a blood clot, we apply warm packs immediately to dilate the vessels. But cellulitis is a raging hot bacterial fire. The tissues are maximally engorged with fluid, the capillaries are leaking massively, and the skin is stretched tight. If you apply heat to an active severe cellulitis, you will cause even more extreme vasodilation, increasing the leakage of fluid and exacerbating the painful swelling to the point of tissue damage.
Applying cool packs first causes mild vasoconstriction. It clamps down those leaking capillaries, reduces the intense swelling, numbs the agonizing pain, and physically cools the burning hot skin. Once that initial destructive inflammatory phase is controlled, the skin softens and the redness fades slightly, then you switch to warm packs. The heat gently vasodilates the area, increasing the local arterial blood flow to bring fresh white blood cells, macrophages, and systemic antibiotics directly to the battlefield to finish cleaning up the bacterial debris.
But the clinical data includes a massive priority warning here. The exact same warning we discussed hours ago with peripheral artery disease. You must use extreme caution when applying warm packs to patients with sensory deficits, specifically mentioning diabetic neuropathy to prevent severe burns.
It all comes full circle. A patient with poorly controlled diabetes has chronic hyperglycemia. That excess sugar damages the myelin sheath of the peripheral nerves in their feet and legs. They develop peripheral neuropathy. They literally lose the ability to feel pain or temperature in their extremities. Furthermore, diabetics are highly prone to cellulitis because that same neuropathy prevents them from feeling a small cut or a blister on their foot, allowing bacteria to enter unnoticed.
If you take a hot pack from the hydrocollator and wrap it around the cellulitis on a diabetic patient's calf, they will not tell you it is too hot. They cannot feel it. You will cause a third-degree thermal burn over an active bacterial infection. You have to check the temperature of the pack meticulously against your own forearm, and you must assess their skin every 15 minutes.
And from a discharge teaching perspective, this is why diabetic foot care is so heavily emphasized. You teach them to never walk barefoot, to inspect their feet daily with a mirror, to wash and dry carefully between the toes to prevent fungal fissures, and to cut their toenails straight across to prevent ingrown nails. You are teaching them to manually protect the barrier that their nerves can no longer monitor. Because preventing the break in the skin prevents the cellulitis, which prevents the sepsis, which prevents the amputation. It is all connected.
Oh, wow. We did it. We have traced the complete pathway. Let's synthesize this incredible journey. We started down at the very edges, looking at the physics of flow. We saw how the narrowing pipes of PA cause the tissues to suffocate and die, forming dry gangrene that we dare not touch. We saw how the broken valves of venous insufficiency cause a traffic jam of fluid, rusting the legs from the inside out with hemosiderin and causing weeping ulcers.
We saw how that stagnant venous blood can form a rogue clot, a DVT, and we learned why we never use Hohmann's sign to assess it. We tracked that clot as it broke loose, shooting into the lungs to become a pulmonary embolism, completely blocking oxygen exchange and requiring immediate high-flow oxygen to save the remaining lung tissue.
We dove deep into the heart muscle itself, understanding the cruel quirk that the heart only feeds itself during diastole. We explored how atherosclerosis causes the predictable pain of stable angina and the terrifying unpredictable pain of an acute MI when the plaque ruptures and the troponin spills into the blood. We learned how morphine saves the heart by shutting down the panic and dropping the preload.
We looked at the tragic, misguided compensation of heart failure, where the body's RAAS system and sympathetic nervous system try to help a failing pump by clamping the vessels and flooding the body with water, ultimately drowning the patient and requiring strict daily waits.
And finally, we filtered it all out through the kidneys. We manage the agonizing blockage of renal calculi by using ambulation and gravity to force the stone out. We monitor the vital perfusion of urinary stomas, and we circled back to protect the skin from the fiery bacterial invasion of cellulitis.
It is a phenomenal, humbling reminder of the profound interconnectedness of the human ecosystem. When you look at this clinical data through the lens of pathophysiology, the nursing process reveals its true depth. You are never just treating one isolated organ. You aren't just memorizing one bullet point on a flashcard to pass a test.
A mechanical failure in the floppy veins of the leg dictates a catastrophic failure in the oxygenation of the lung. A failing heart pump destroys the delicate filtration of the kidneys, yet the radiopaque contrast dye we use to save that heart can also destroy the kidneys. A diabetic's inability to process sugar destroys the nerves in their foot, which prevents them from feeling a blister, which leads to an infection, which you must be careful not to burn with a warm pack.
You are managing a delicate, high-stakes, constantly shifting internal environment. Everything touches everything else. A single intervention in one system causes ripples through all the others.
The butterfly effect of human physiology. One tiny flap of a plaque rupture, and a hurricane of systemic failure follows.
Yeah.
So here's a final thought for you to mull over as you step onto the floor for your next shift, or as you sit down to master this material. Think about the incredible, stubborn resilience of a system that can bypass its own blocked arteries, grow brand new collateral vessels, and shift entirely to anaerobic metabolism just to keep a patient walking to the mailbox.
But also hold in your mind how quickly that same magnificent resilient system can be completely and utterly undone by a single traveling blood clot the exact size of a grain of rice.
How does balancing that incredible resilience against that terrifying fragility change the way you look at the patient sitting in front of you? Thank you so much for taking this deep dive with us. We know that by mastering the why, you are going to be an exceptional clinician. Just remember, don't look for the clean, jagged line on the x-ray. It's not about memorizing the parts. Look for the flow, respect the pressure, and always look for the mechanism underneath. Good luck, and we'll see you next time.